Migraine, unilateral, localized pain, frequently accompanied by nausea, vomiting, and sensitivity to light and sound. Epidemiology, more common in females than males. Duration, 4 to 72 hours. Frequency, up to several times per month. Age of onset, typically during adolescence and early adulthood, 15 to 25 years of age. Therapy, NSAIDs or triptans, antiemetics for nausea. Remember, overuse of triptans can cause medication overuse headaches. Course of an attack. Pain intensity is this during potential neurophenomena, and pain intensity is this during migraine attack. Triggers. Weather changes, alcohol, stress, physical activity can trigger migraine. In females, menstruation and oral contraceptive pills are additional triggers. Character of pain, pounding, throbbing. Additional symptoms related to migraine are nausea, vomiting, anorexia or excessive hunger, phonophobia or photophobia. 25% of cases of migraine are with aura phenomena, 75% are cases without aura phenomena. Prophylaxis, lifestyle changes, for example, endurance sports and stress reduction. Epidemiology, peak incidence 30 to 39 years of age. People have migraine younger in age, but they do not represent to physicians. So peak incidence reported is 30 to 39 years of age. Migraine is the second most common type of headache. The first most common type of headache is tension headache. Among patients presenting to the emergency department with a headache, migraine is the most common cause. Etiology: the exact pathophysiology is unclear. Genetic predisposition, that is, in monozygotic twins and siblings, there is more probability of migraine if one of the siblings has migraine. Potential triggers: certain food and beverages, nicotine, citrus fruits, alcohol, dairy products, food containing tyramine, for example, chocolate, red wine, fasting, dehydration, poor sleeping habits, emotional stress, weather changes, hormonal changes in women, menstruation, hormone intake, oral contraceptive pills. These are the 6 common migraine triggers: missing meals, eating certain foods and drinks, chocolates, changes in sleep patterns, weather changes, hormonal changes, stress and strong emotions. Clinical features: the typical migraine headache is bound, P pulsatile, O 1 day duration, U unilateral, and nausea, D disabling. Prodrome: 24 to 48 hours before the headache starts, excessive yawning, difficulties with writing or reading, sudden hunger or lack of appetite, mood changes. Aura: aura is paroxysmal, completely reversible focal neurological symptoms that develop gradually and precede the headache. Visual disturbances, sensory and/or speech symptoms, sensory deficit paresthesia, paresis, dizziness. Aura consists of focal neurological symptoms that are completely reversible. Headache localization, typically unilateral, but bilateral headache is possible. Unilateral headache can also switch sides. Headache is especially frontal, frontotemporal, retroorbital. Duration is usually 4 to 24 hours. Course, progression of pulsating, throbbing or pounding pain, exacerbated by physical activity, accompanying symptoms, photophobia, phonophobia and nausea or vomiting. Post-drome, feeling of exhaustion or euphoria, muscle weakness, anorexia or food cravings. Subtypes and variants of migraine: migraine with brainstem aura, dysarthria, vertigo, tinnitus, diplopia, ataxia, hearing loss, impaired consciousness. Vestibular migraine, vertigo, anti-vertigo agents, for example, dimenhydrinate can be used. Hemiplegic migraine, motor weakness, visual impairment, sensory or speech impairment. Retinal migraine, aura occurs in one eye, scotomas, that is visual field effects, blindness. Keep in mind that aura consists of focal neurological abnormalities which are completely reversible. Typical aura without headache, silent migraine. Aura symptoms are present, headache may not develop. Chronic migraine. Patients with migraine diagnosis with a more than 3-month history of the following: headache for more than 15 days per month, more than 8 days per month migraine headache, or headache relieved by migraine specific medications. Avoid anchoring bias in patients with known migraines and pursue a diagnostic workup for headache in patients with red flags for headache. All variants of acute migraine should raise suspicion for other diagnoses. For example, transient ischemic attack, especially if the first aura occurs after 40 years of age. Auras last an atypical amount of time. Our symptoms are predominantly negative. For example, paresis, visual field effects, etc. A new or progressive headache in a patient aged more than 50 years may indicate tumor or hemorrhage and should always be treated as a high-risk headache. This is a lady who has previously migraine. Now she presented with headache and ptosis of the right eye. On opening the right eye, there is mydriasis, dilatation of the pupil, and gaze misalignment towards lateral side. These are the characteristic features of oculomotor nerve palsy. In this case, oculomotor nerve palsy was due to aneurysm. Diagnosis: migraine is a clinical diagnosis that is based on patient history and physical examination. Lab studies, not routinely indicated. Consider a urine pregnancy test to guide pharmacotherapy choices in women of childbearing age. Imaging: neurological imaging is not routinely indicated. Treatment of migraine: abortive therapy for migraine. Limit stimuli, that is light, loud noises and activity. In mild to moderate headache, ibuprofen, aspirin, acetaminophen, aspirin, caffeine. And these all can be given per oral. Ketorolac, diclofenac can be given IV. Children, ibuprofen and family counseling. Moderate to severe headache, parenteral antidopaminergics, metoclopramide, prochlorperazine, plus diphenhydramine. Migraine-specific agents, triptans, for example, sumatriptan, ergotamine, for example, dihydroergotamine. Additional agents, calcitonin gene-related peptide receptor antagonist, for example, ubrogepant or imegepant, 5-HT1F agonist, for example, lasmiditan. And this is the abortive therapy for migraines, that is therapy during the attacks, NSAIDs, antidopaminergics, triptans. This is the therapy during attack. In pregnancy, acetaminophen can be given. NSAIDs are safe till the second trimester of pregnancy. Metoclopramide can be given in pregnancy. Triptans ergotamine should not be given during pregnancy. Prophylactic therapy of migraine, lifestyle modifications. Lifestyle modifications are having regular sleep pattern, and doing yoga, moderate exercise, and healthy diet. Pharmacological, first line are anticonvulsants, for example, topiramate, divalproex, beta blockers, for example, propranolol, metoprolol, timolol. Beta blockers can be given during pregnancy for prophylaxis. Anticonvulsants cannot be given. Second line are tricyclic antidepressants, amitriptyline, NSAIDs, phenoprofen, other calcium channel blockers, for example, flunarizine. Calcium channel blockers can also be given during pregnancy. Menstrual related migraine, first line provatriptan, second line naratriptan, zolmitriptan. Chronic migraine, botulinum toxin and monoclonal antibodies. anti-calcitonin gene-related peptide or anti-calcitonin gene-related peptide receptor antibodies, for example, iranimab, etc. This is the prophylactic therapy of migraine. Migraine headache self-care tips to manage migraine: meditate, for example, yoga, consistent sleep schedule, eat wisely, that is healthy diet, don't avoid exercise, moderate exercise can be done. Parental antidopaminergics, that is IV metoclopramide or IV flucloperazine, are effective first-line agents for migraine, regardless of GI symptoms or ability to tolerate oral medication. In the emergency department, consider IV dexamethasone to reduce the risk of recurrent migraine after discharge. IV dexamethasone prevent migraine attack for up to 72 hours. Acute management checklist: migraine of any severity. Consider CT or MRI of the brain with or without contrast if the presentation is atypical or red flags for headache are present. Usually MRI is preferred for headache. If there is suspicion of brain hemorrhages or there is an emergent event, CT should be done because it takes much less time than MRI. Reduce light or noise in the patient's environment. Fluid hydration. Begin pharmacologic treatment within 1 hour of symptom onset if possible. Treat nausea or vomiting if present. Mild to moderate headache. Start a non-specific agent, for example, NSAID, acetaminophen, or combinations including caffeine. Moderate to severe headache, or if the above treatments fail, consider trialing a parenteral antiemetic, that is metoclopramide or prochlorperazine. Start a migraine-specific agent, first line oral or parenteral triptans, second line parenteral ergotamines. NSAIDs can be combined with triptans or ergotamines for more beneficial effect, but triptans and ergotamines should not be combined in any case. Consider early recurrence prevention with dexamethasone. Status migrainosus refractory to the above. Escalating therapy with antiemetic, NSAID, dihydroergotamine, dexamethasone, and valproic acid. Consider inpatient treatment. Neurology consultation. Consider alternative diagnosis, for example, medication overuse, headache, intracranial hypertension, brain hemorrhage, etc.